Okay.
So I'm happy to be with prominent faculty, and I'll try to share the experience regarding our procedures which we perform for degenerative spine stenosis. We last couple of years were doing it mostly with the percutaneous minimally invasive endoscopic way, and actually the normal algorithm of the treatment of spinal lumbar stenosis is start from some pharmaceutical therapy and then some minimally invasive percutaneous procedure. Then the normally neurosurgeons start perform some decompression procedure with instrumentation. And due to many different limitations of performing big procedure, we try to find the alternative way to do it minimally invasive and especially in endoscopically percutaneously. So the reason how to perform the procedure for endoscopic way, it's algorithm which we finally used, which based on the idea that there are different kind of stenosis. We subdivide the stenosis with central in case if it less than 10 millimeters of transsectional area, or lateral in case if we have the minimal diameter of lateral recess less than 2-3 millimeters. And also we have some additional characteristics of lumbar spinal stenosis like stenosis type, central, lateral, foraminal stenosis, we all know about it. And of course the elongation of the stenosis, if it leads to 1, 2, 3 levels, and the level of instability, it also provide certain algorithm of instrumentation in case of the stenosis decompressed. So we analyzed the current classification of lumbar spine stenosis, and normally the classification developed by Professor Shizas in 2010 used for it, and this is the classification which based on relationship between the neurostructures and liquor, depending of the level and the severity of compression of the neurostructure neural root in the lumbar canal. The level of stenosis is subdivided for 7 degrees. So we also used last 2 years the algorithm which include the indication for minimal invasive decompression created by a group of headed by Dr. Timothy Deere. And here you can see that in case if we have so-called stable lateral or central stenosis, some kind of direct or indirect minimal invasive decompression could be implemented. I mean, that's in case of the yellow ligament could be, for example, stretched. The indirect decompression with a like sleeve procedure could be offered. But if the resection of yellow ligament, for example, or other compressive structure should be removed, the direct minimal invasive procedure, like, for example, our discussable procedure like endoscopic percutaneous, lumbar stenosis decompression could be also performed. So we also published our minimal invasive spine decompression algorithm in different paper. So depending on the anatomical structure, which stenosis, central stenosis or lateral stenosis, so the procedure like percutaneous endoscopic lumbar discectomy or decompression procedure could be done via intralaminar approach, via posterolateral approach, or transforaminally. In case if we have compression provided by bony spines, bony osteophytes, or lateral stenosis, we perform portal or so-called easy-go portal navigated approach, very popular now. I mean, that's depending on the location of compressive structure, lateral, unilateral, or both sides. And in case of prevalence of symptomatic monoradicular providing the foraminal stenosis, in this case, we are normally doing percutaneous endoscopic decompression procedure on the lateral side, called based on the instrumented productive company Dermastasis transforaminally. And if we're doing the transforaminal approach, we normally position in the cannula, check the level, and it's actually the half of this procedure doing by fluoroscopic navigation. So via the cannula, we can remove the part of annulus fibrosus, then remove the herniated disc in lateral way. And it's also quite popular in case of lateral stenosis. That's the procedure so-called in-out. I mean, that's the procedure going, the instrument going from the disc to the canal. So if we introducing the cannula to the disc, we can remove the part of the disc. It's now seen, I hope, on the video. Then we remove the part of the disc which bulges into the canal. Then the checking of the canal itself. And then you can see the neurostructure, the transversion nerve, and to be sure that the decompression procedure is done. Then another story when the patient has the actually real stenotic process inside the canal, and polyradicular normally scenes and sometimes claudication. And then the procedure named intralaminar endoscopic spine stenotic decompression, or delta, as the instrumentation used for this way. Last 2 years, we increased the amount of this procedure dramatically, and now doing 40 to 50 procedures per year. And it's very convenient because we can use the quite big cannula, which located exactly intralaminary. And of course, it's somehow limited. I mean, that should be enough space for manipulation of this cannula, but finally, the procedure itself, the same as we're normally doing for spinal stenosis, and the instruments quite similar, but of course, you don't need to destabilize the spine. That's why I would say that's the learning curve for this operation quite understandable for the surgeons who are doing this surgery in general. So finally, the operation based on the several normal steps for the spinal stenosis. We start for intralaminar approach and the resection of facets. Then the spreading with high-speed drill the intralaminar space, and then start resection of the ligaments. And it's always starting with yellow ligaments in the central part of the sac, the cover of the central part of the sac. Then we are doing the decompression of the yellow ligament for the unilateral side of the spinal canal. Of course, some partly resection of the medial border of facets is necessary in this way, but you can easily see the root because you can palpate it, and actually because you have the pressure of the irrigation water, you can always see the border between the neurostructure and the bony or ligament structure. So the decompression on the site of the surgery and the decompression of the contralateral radicular over the top technique is very easier That's why nearly you can perform from one side the decompression of all the level, and then if it's necessary to perform several levels of decompression, so the cannula should be repositioned, and it could be done on this in another level. And of course, you couldn't see the complete relation between the Röntgen after the surgery, MRI control, and real clinical follow-up. But in general, normally we can reach the double of area of transverse area of the cross-sectional area of the spinal canal, and it reach from 0, you know, the minimal, the critical area for spinal stenotic is about 1 square centimeters, but we can reach the level of 1.3 centimeters and more. So it's nearly double the transverse transsectional area of the spinal canal. And in all cases, the results is very dramatically. On the first day, the patient feel the reduction of the pain and the reduction of claudication. Of course, the procedure provide the early rehabilitation for this patient, and all percutaneous irrigating procedure reduce the bleeding, operating time. The patient could be discharged from the hospital next or second day of the surgery. Okay, where normally have them 3 to 4 days, but not more. And in general, result is quite impressive. The contraindication for this procedure, for full endoscopic procedure in spinal stenosis, is really bony osteophytes, which couldn't be resected on this way because the instrument quite small, and severe paresis or fast developing neurological signs could be a contraindication for this procedure. We always remember that we have to have 1 centimeters, 10 millimeters minimum intraluminal space, because you have to introduce this endoscope to this place, otherwise you could manipulate there. And as I told, the reducing of the pain in the first day, we have nearly for all the patient, and according to ODI score, McNabb criteria, the good results after the surgery reach 75 to 80%, and it's quite long. So we have follow-up for the 1 year, and most of the patient preserve the results which come in the first or second day after the surgery. And it's concordant to another investigation this way. We always remember, of course, that there should be some learning curve anyway. According to investigation of Morgenstern, Anthony Young also included there, the real high result after the percutaneous endoscopic procedure could be the best after the 90s procedure, 80 to 90, 82 procedures. And we also think that especially the time of the surgery, which could be less than 1 hour, 60 minutes, could be reachable after the 40, 50 to 60 procedures, and then all the manipulation could be quite easy. But as I told in the beginning, the endoscopic percutaneous spine stenosis decompression is quite understandable. I mean, the instrument's the same, the view on the screen of the endoscope is quite understandable for the surgeons who perform it microscopically or endoscopically via port, etc. So, in conclusion, I think that the still conservative treatment for symptomatic spinal stenosis is less effective than real decompressive surgical treatment, and of course the treatment choice depends on the degree and level architecture of the stenosis. But for our opinion, the percutaneous endoscopic spine decompression for lumbar stenosis is quite attractive alternative for another kind of treatment. Thank you for your attention and sorry for some technical things in the beginning. Thank you.